Good afternoon, WellStar team members, and thank you for joining us for Inclusive Insights, WellStar's Office of Diversity, Equity, Inclusion, and Belonging's Enterprise Speaker Series. My name is Tia Douglas, and I serve as the Senior Program Manager in the Office of Diversity, Equity, Inclusion, and Belonging. This series is dedicated to introducing you to national thought leaders and innovators in this space. Our goal is to inspire a growth mindset on all things related to diversity, equity, inclusion, and belonging. Through this platform, we will elevate the conversation and seek to broaden awareness of how diversity, equity, inclusion, and belonging is connected to all that we do and is a critical aspect of our development, success, and growth as leaders and individual contributors. During today's presentation titled Empowering Voices, Bridging Communities, Celebrating Interpreters, we will hear from Carla Fogren, President of the National Council on Interpreting Healthcare, and Debbie Lesser, Director of Language Access Services here at WellStar. Debbie and Carla, thank you both for joining us this afternoon. And now I will turn the program over to you.
Thank you so much. I am so excited to be hosting today's Lunch and Learn in honor of National Interpreter Appreciation Day. I would like to give a shout out to WellStar's amazing interpreting team. We have almost 50 extremely dedicated and talented interpreters and translators who work alongside our team members to provide exceptional care to our patients every single day. Today, I have the pleasure of discussing the topic of interpreting services with my good friend, Carla Fogren. Carla was born in Angola, Africa, and is fluent in Portuguese. She's been an interpreter since childhood. Carla, you can tell us about that in a moment. And Carla's been an RN with over 30 years of clinical experience. Carla managed language access services for a large healthcare system with over 42 hospitals in 11 different states and over 6,000 physician practices. As of yesterday, Carla ended her tenure as president of the National Council on Interpreting in Healthcare. Congratulations, and now serves as vice president. Currently, Carla works as a national consultant and an expert witness in litigation involving language access and healthcare systems. It is my absolute pleasure to have this conversation with you today. Although we have a ton to discuss, before we do that, I'd like to kick us off with a phenomenal video honoring our interpreters and the work they do here at WellStar. I hope you enjoyed that video. I'm so proud of it. It's awesome to honor our team like this today. Before we get started, I do want to say, as we go through this dialogue, Carla and I, if any of you have questions, please use the Q&A throughout our discussion. I'm monitoring the Q&A throughout the hour, so I'll try to address your questions or have Carla address your questions as we go forward. So without further ado, Carla, the first thing I want to do is really define the three different things, the three things that we're going to be talking about today: interpreting, translating, and bilingual fluency. So I just want to make sure everybody understands the difference, and that'll give us a really good foundation to jump into all of our discussion questions. So interpreting is, and Carla, you add to what I'm saying if I misspeak at all. So interpreting is going from one spoken language to another, or spoken language to sign language. But it's typically considered oral, whereas translation is all considered to be written. So when you need a document translated, you would use a translator. When you need an interpreter to come in and interpret between a nurse and a patient, then you're using an interpreter. And not all interpreters are translators, and not all translators are interpreters. And then there's bilingual fluency. So, you, Carla, are your first language is Portuguese, but long before you were an interpreter, you were bilingual. And so, bilingual fluency, just because someone is bilingual, doesn't mean that they can automatically interpret, right?
Absolutely. And first of all, let me just thank you all for having me here. Debbie could convince me to do anything, in all honesty, but it's such a well-run organization that it's my honor to be here with you today. And congratulations to your fine team of interpreters. I mean, they really are the ones that keep things going, because without communication, we would just be performing veterinarian medicine. Even though I swear my dog does speak, but other than that. So you're absolutely right. I mean, when you said that most interpreters are not translators, it's actually a very high number of interpreters are not translators, or vice versa. So, and being bilingual does not make you an interpreter or a translator either. So very good points. And I hope that that kind of lays the foundation for our discussion.
Absolutely. So here at Wellstar, we used to offer a 40-hour training to our bilingual team members, and allowed them to interpret in their departments. We stopped doing that in 2017, but I'd love to hear your thoughts, because a lot of people think, well, I just need this 40-hour training and then I can interpret. How hard can that be? So tell me a little bit about your opinion on that.
I have to tell you, it was mortifying when I was bedside nurse and I was an ER nurse, when they would call me over for a Portuguese patient, because the way that I interpreted things was pretty bad. And that's when I realized I really need to find out what interpreting is about and get myself better versed and trained and qualified. So just being bilingual and completing a 40-hour training course is just not enough. I mean, think about 40 hours, that's 1 week. While being highly fluent in at least 2 languages is a fundamental requirement, interpreting is much more complex, and it involves a lot of complex skills that go beyond language proficiency. You know, interpreters need to have a deep understanding for both languages, including grammar, and actually a third language, medical language, right? The medical vocabulary, the slang, the cultural nuances. Yes, we even have to know how to curse in both languages. That was a stretch for me. You need excellent listening, speaking, and memory skills to accurately interpret between languages in real time. I remember that at my height of my interpreting profession, I could retain about almost 3 minutes worth of dialogue, which I was so proud of. But, you know, it took a lot of practice and a lot of hard work for that. We need the specialized vocabulary knowledge to be able to interpret accurately complex topics. And let's face it, everything in medicine is or can turn complex within seconds. While you may be a podiatrist, for instance, you're a medical doctor, you went to medical school, you've got a good understanding of general medicine. You may not feel that comfortable with all the terms and procedures related to cardiology. So while an interpreter has to be versed in all disciplines and have a very deep and broad range of vocabulary, as an interpreter, 1 minute I will be doing a birth, a happy moment. The next minute I may be giving the diagnosis of stage 4 cancer to a 40-year-old. And the next minute I'm actually helping spiritual care with the last rites of saying prayers. which was something I never thought of doing as a medical interpreter. And boy, did I have to get well versed in those. So again, communication can sometimes break down because if the interpreter doesn't understand the cultural nuances. For instance, a certain word in European Portuguese, which is what I speak, could be extremely insulting in Brazilian Portuguese. And if I, as the interpreter, am using that triadic relationship between you as the provider or the clinician and the interpreter and the patient could completely be derailed, creating an atmosphere of distrust. And like, I can't believe the doctor or the nurse said that to me, because they can't often distinguish that it is more of a cultural nuance, right? And that can result in a patient being non-compliant with the treatment plan, right? The other thing, Debbie, that you and I talked about was untrained staff may not be familiar with the first person. Even when interpreters get trained, that's a whole thing to wrap their head around, right? Interpreters
What do you mean by that, by the first person?
Like, for instance, interpreters are encouraged to have you as the doctor speak directly to the patient, right? Versus saying, Mrs. Duvalsant, how do you feel? They should be saying that instead of saying, could you ask her how she feels? So that the communication is direct to the patient, you know? If you don't establish that, it's kind of an awkward way of talking. And sometimes the struggle is really that the patients and staff do not understand our role. And that's why it's critical that interpreters do the formal introduction at the very beginning of the session so that they know what your role is, they know everything's confidential, they know that you're going to use the first person. I have a favorite surgeon, and when I say favorite, I allowed him to operate on me, so he's definitely a favorite. When he was assessing a elderly Portuguese-speaking lady that had just come back from Cape Verde, actually, he asked how she felt, and her response through me was, I feel awful. My stomach is acting up, and I feel like I have to move my bowels all the time. He turned to me somewhat alarmed and said, Carla, if you don't feel good, we can do this later. Because he didn't understand that I was conveying directly from the patient, right? The other thing that's important, and you know, we're all human beings. At the beginning of the day and at the end of the day, there's a lot of social banter that takes place. You walk into the room, the nurse or the doctor that you know says, hey, did you watch that baseball game last night? Well, the patient's right there. It's vital that we interpret everything, everything. No party should be without the understanding of what is being said. This happened to me with a doctor in the ED. His daughter played soccer with my daughter when they were younger. My daughter went on to Division I soccer, and he repeatedly kept asking me, how is she doing? I interpreted it for this elderly Haitian patient, a Cape Verdean patient, excuse me. And the woman with great pride said, my granddaughter is the first one to graduate from college this year. I interpreted it back to the doctor, and he said, well, what college is she going to? That magical moment where that connection and that conversation became theirs, not mine. You know, I mean, he could have asked her to do anything. She trusted him because he was now conversing about what was important to her family, right? So there are the times, Debbie, you and I have gotten into some heated debates with other people about this, where the patient doesn't understand English. And I hear things from providers or nurses, you know, who are not having the best moment, saying things like, why can't they just learn English? I mean, honestly, why is it us that has to respond to this? So I just caution you that if there's something you don't want the patient to know, don't say it in front of an interpreter and that patient, because it will be interpreted. So again,
tell me a little bit. We're talking a lot about patients, but tell me a little bit about what happens if the patient is a child and speaks English, but mom is the one who doesn't speak English.
Well,
you know,
legally,
am I still obligated to provide an interpreter? And
absolutely, legally, the guardian is the parent. So even though the child speaks English, you have to provide an interpreter for that guardian, who is the parent, or even if it's a legal guardian for a patient that's an adult. So, you know, it gets challenging, right? And, you know, at one point in my career, I thought, well, if the child's 16, I mean, isn't that good enough? No, it isn't legally good enough. They're not an adult. So, you know, it gets tricky unless they, you know, there are some circumstances where some certain state laws will allow it, like in Pennsylvania, they can be considered an adult at a certain age. But in all honesty, you just have to provide an interpreter because you also don't know. I was really good at this as a child. Don't think any worse of me, but you know, as a child, I let my parents know what I wanted them to know. So if I
Right.
was actually even interpreting for them, I would always be the angel. I would never tell them what I was up to, what the person was saying about me that was not good, right?
Mm-hmm.
So again,
Mm-hmm.
it also disturbs the power balance between parent and child,
Yeah.
you
Yeah.
know?
Absolutely. One of the comments that just came through from one of our physicians is that this physician is bilingual, but their medical training was done in English. So, so all the medical terminology that they learned was in English. So, talk to me a little bit about, I know we're kind of going out of order, but talk to me a little bit about the challenges that, as interpreters, you had just said that, we have to be well versed in so many different specialties. Whereas if you're a physician practicing cardiology, your specialty is cardiology. And if somebody has a GI question, you're going to refer them to a GI doctor.
Yeah.
As interpreters, we really need to be well versed in so many different areas. But so talk to me a little bit about those challenges, but also can you address the fact that you may be bilingual, but if you got your medical training in English, how does that impact your ability to speak to patients?
Well, I mean, I'm a perfect example of that. I mean, I went to nursing school in this country. So Portuguese is my first language, but I spoke 5 when I came over from South Africa. I was born and raised in Angola, raised in South Africa. My mom's a real linguist. So, the reality is I also was one of 3 girls. So there's a lot of terminology that culturally we did not address. We don't address body parts. We don't address certain things. It's very culturally driven. So I had to learn things that, all of the medical terminology. Now, that doesn't mean that you can't learn medical terminology. What I would say to this physician is, I can't teach him to speak the language, right? But you can learn medical terminology. If you were on the side of the road and you found somebody laying there that got hit by a car, and they were still conscious, you would be able to triage them and you'd be able to speak to them, and you'd be speaking to them in layman's terms for the most part. You would not be saying, well, I think we're going to have to do a cholecystectomy or whatever. You're going to be speaking to them in layman's terms. But that's not enough. Our conversations with patients require us to know the medical terminology. For instance, we had one physician who thought they were very fluent, and they were conversationally extremely fluent, but they told the patient that they were going to replace her kidney versus her knee. Kind of a big difference because they didn't know the terminology. So, and then there were other times when, well intended, it's like a pantomime. We try to say this, and we go into the slow and louder version of whatever language we're speaking. And that is not helpful for the patient. So I would say, check with Debbie. She may have glossaries and terminology that would make you feel more comfortable. But, you really have to have that terminology. I've had nurses go into a patient's room with 2 years of Spanish and say, hola, or in Portuguese, how are you? And then all of a sudden, something that turns into like just a check-in, the patient goes, a dor no meu peito, e não sei o que está acontecendo. And you're like, oh my God, what just happened? And that's a patient having chest pain. So how do you take that if you're not fluent enough to be able to identify it and act on it? So I hope I answered that question. I know that we're going to discuss bilingual fluency a little later as well.
Yeah, definitely. The next question that I have is, oftentimes as an interpreter, I'm asked if I can help with moving a patient or turning a patient in the bed or helping, or not telesitting, but sitting with a patient. And I, our interpreters we talk about scope of practice a lot with our interpreting team. So tell me a little bit about that, an interpreter's scope of practice.
Well, I mean, an interpreter's scope of practice is essentially, we are trained and qualified to convey messages from one language to another language, right? And to do so almost instantaneously, which is not easy to do. and to have the memory skills that will help you retain all that. So, I'm a nurse. I told you I'm a registered nurse. I feel like I'm pretty competent. However, now you want me to float to the OR. No way. There's no way. I'll be running out the door. I am not trained and qualified to do that. So moving or feeding a patient involves physical tasks and direct patient care, which really is the responsibility of nurses, doctors, certified nursing assistants, and ancillary help, right? Interpreters don't have the necessary training or qualifications or even the legal authority to do these tasks. So they would be operating outside the scope of practice, and this can lead to potential risks and liability. This happened all the time. Can you sit with this patient? Can you be a safety sitter? Could you feed this patient? Or, do you mind driving them home because they don't have a ride? All of this is a hard no. This does not fall into the role. And sometimes interpreters feel pressured to doing what that physician wants or the nurse wants because we have such tremendous respect for people, right? But no, it's completely outside of scope. God forbid that person that you were feeding end up aspirating. Who is going to get blamed for that? Both the hospital, but that individual that was doing something out of the scope of their practice.
Yeah, absolutely. Great answer. Okay, next question. And by the way, all these questions were kind of on my list of frequently asked questions, so that's where I came up with them. So next question is, family members, we all know that they have the patient's best interest at heart. So what's the harm in using a family member to interpret? I mean, you alluded to the fact that, as a child, you didn't allude to, you were very clear about it. And by the way, if you all haven't seen the movie Coda, it's a fantastic movie about one hearing daughter in a family of deaf individuals, and there are some really funny scenes in there where she has to interpret for her family. It's a great movie. But what, aside from the fact that you can be very selective about interpreting what you choose to interpret as a family member, but what are the risks, I guess, of using family members to interpret?
So I think your family may be more functional than mine. Mine might be more dysfunctional, but the assumption that everyone has the patient's best interest at heart is just an assumption. There are nice people out there, and there are not so nice people that have ulterior motives. So family members or friends may not have the necessary language proficiency or interpreting skills to accurately convey things. And for instance, I took an aunt for a colonoscopy. Now, one of the risks is that we could perforate her bowel. So I interpret everything. And she slapped my hand. She said, "Why would you bring me to a place that can kill me?" Right? So oftentimes you leave out those things because if you say everything, they won't proceed with the procedure. And that is not fair to that physician who's risking his or her license by disclosing all of this, right? So it could potentially have harmful consequences for the patient's health. The other thing is confidentiality. Are you kidding me? Family members or friends may inadvertently disclose sensitive information about the patient, right? Violating confidentiality and compromising the patient's privacy. However, think about your own family. Is there someone in your family that you feel you would not want to have involved in your care? Perhaps that nosy cousin who you're utilizing as an interpreter. By 2 p.m., everyone today in Atlanta will know that you have an STD, okay? Because they're blabbing everything. This conflict of interest, Debbie, what do I get out of this? Perhaps I don't want you to come back home because I can't take care of you. So I'm going to augment what's happening with you. Perhaps we've seen this. You and I have seen this, where lawyers come into the hospital to have patients sign over things, but they're using a family member to interpret. And that family member is going to interpret whatever they want to say, right? But the emotional impact, last but not least, in these emotionally charged situations, you're delivering bad news or discussing very sensitive medical issues. A daughter may not want to talk to her dad in front of her dad about the erectile dysfunction. I mean, think about it. Common sense is just not common sometimes, right? It can really prevent you from communicating, and it can affect the clarity and the effectiveness of this. I'll share something with you personally, because now all of WellStar is family. As I told you, I was born in Angola and raised in South Africa. At the age of 12, we migrated to New Bedford, Massachusetts, which is like the Portuguese capital of the United States, honestly. Big fishing, the biggest fishing industry in the country. My dad was a welder on the fishing boats there. And about 2 years after we arrived, he was 43. He started getting massive, massive headaches and a lot of dizziness. And he was admitted. And I remember the doctor and nurse walking down the hallway into the waiting room, which had, by the way, my whole busload of relatives, my godparents from confirmation, my grandparents. We don't travel lightly. We have an extended family. And, they asked, does anybody here speak English? And my mom got up, and she's a linguist. She speaks 7 languages fluently. She could not say anything other than Portuguese, which is not uncommon. We've even had stroke patients or epileptic recovery patients who come back in a language that they haven't spoken in years, right? So the brain is a phenomenal thing. So I, at 14, stood up and I said, I speak English. And he proceeded to ask me to tell my family to let them know that my father had a terminal brain tumor. So at 14, I was just trying to think, do I know these words? Can I say these words? And honestly, I was so focused on the terminology that it wasn't until my grandmother fell down wailing, and if you've heard people wail, it's quite the sound, that I realized that I had just delivered my dad's death sentence to my whole family. My grandmother never looked at me the same. I think she always connected me with that moment.
Yeah.
And it's left an indelible imprint on my soul. And no child, no matter how old they are, it could be me at 61. Don't ask me to deliver that news. Let
Sure.
us be the sister, the wife, the daughter, and get a professional interpreter to help communicate. Because it's just not right. It's not fair. And it just, the lingering effects remain.
Absolutely. And you also said that every time I hear that story from you, it touches my heart because it's so traumatic. And I know a lot of the interpreters on WellStar's team have shared very similar stories. One of the things that you said was that your mother, who knows 7 languages fluently, could only think in Portuguese. And that is one of the things that happens when you're in crisis, is you go back to your first language. So again, so someone may answer, yes, I speak English fluently, but in that moment of crisis or stress, they're just not able to think clearly. So in a normal everyday situation, they may be much more effective than they are in a crisis like this in general.
Think about it, Debbie. The common sense advice is that if you're going to a doctor's office, bring somebody with you to kind of listen to what's happening, right? Because even if you're a nurse, you're kind of like a little stressed out. Now imagine being that stressed and then not understanding blah, 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 blah that's happening and having to convert it into 2 languages. It's just too much. And, and it was something that at age 14, I grew up fast because he passed in 2 months, and, it's just moments like they weren't going to send him to Burlington to lay clinic because they didn't think that my mom could find her way. This was the 2nd day. So we're listening to them converse about this. And my mom said, no, I want to do everything I can to save my husband or to help prolong his life. I will find my way. Now, this is 1977, well before GPS or anything, right? Or Waze or anything. But the fact that they were going to make a decision based on the fact of the biases that they didn't think my mom could find a way out of New Bedford. This is a woman that's traveled all through Africa on her own and can certainly read a map. This was a further injury. And then they actually said, and we need you to take him home because there's nothing we can do for him. And this is the flu. We have a flu breakout, and we need the beds for people we can help. So our first experience with the medical system was not really a very endearing one. However, we had a great visiting nurse who then completely motivated me and encouraged me, and I became a nurse as a result of this. So not all bad, but it's putting yourself in the other person's position, which we sometimes are too busy. It's not like we're mean-spirited people. We're just too busy to do.
Right. Understood. Yeah. So there are over 6,000 languages across the world. And try as we may, we have, I'm sure you've encountered this too. We have had situations where we just can't find an interpreter in that particular dialect. Or our Spanish interpreters are asked all the time to interpret in Portuguese because it's close enough, right? So can you address a little bit of that? What do we do when we can't find an interpreter in that language? And before you answer that, let me just say to anyone who's not aware, Wellstar has multiple vendors that we contract with. So we staff Spanish and sign language. And I also forgot to mention, Wellstar is the only healthcare system in the state of Georgia that actually staffs ASL, American Sign Language, interpreters full time. We're the only healthcare system that offers that. So that's wonderful. So what do we do when we can't, they've contacted interpreting services and we can't find an interpreter in a rare dialect?
So first of all, congratulations on that, because ASL, as you know, is hard to find sometimes when you need it the most, right? So this gets a little tricky. This is where I kind of get torn between being a nurse and an interpreter, right? As a nurse, I just want to get to it, right? I want to just give me what I need,
Yeah.
But as an interpreter, I know that giving the person what they think they need may not be the best thing to do, right? So this happens all the time. I mean, sometimes it's a dialect that's so rare that there's actually only one interpreter in the United States that speaks it. So I would suggest, and I don't know if you have this in your policy, but I included this in my policy, that it's not good enough for you to just be able to say after the fact, when they're looking at this from a legal perspective or risk and compliance, like, I couldn't find an interpreter. You have to be able to document that you went through vendor number 1 to no avail. Vendor number 2 did not have anybody. So I would recommend to utilize an employee that spoke that language first, if you have one. Chances probably are slim and none, because if it's that hard a language to find, you're maybe not going to come up with a doctor or nurse or an employee that speaks it. But then you would go to the family member. Only in the interim, while you're still working really hard to secure an interpreter that's qualified.
Sure.
The other thing is, for instance, but you have to document it. We had a resident that I was involved with a case who documented that he utilized a family member, a child, and because it was an emergency. Well, when we try to figure out what the emergency is that he had his first date with someone that evening. That is not an emergency. Let me qualify that. It's got to be a medical emergency, like life or death. So let's say I'm in for a procedure that's not critical. It's not like timely that it has to happen right now. Then give yourself the grace of time, if you have it, to not do the consent form without an interpreter. Wait till we can see if we can secure an interpreter. Because in essence, you're asking that patient to sign something about an invasive procedure that they have no idea of what you're going to do to them, right? So it's not an easy answer, but, we are tasked for doing no harm first, right? And we got to work on the premise that we've done everything we can, but you can't just make that decision on the second floor in some inpatient unit without consulting the experts like you, Debbie. If you meet resistance on one end, make sure you consult the very experts that you have in your system, because they may have some other creative solutions. And this is why it's so important. And you hear me talk about this. You need an in-person interpreter staff. You need to have agency interpreters that are great, that you have a good partnership with. And you need video and phone interpreters. You need all of those modalities. God knows during COVID, that was the only way we survived, correct?
Yeah, absolutely. Yeah. So you had mentioned interpreter shortages for ASL. There are interpreter shortages all over the place. So one of the things that Wellstar is going to implement is ensuring that our bilingual staff are qualified to speak in whatever their languages are. But can you talk a little bit more about those folks interpreting? So if someone has been qualified and we know that they can speak fluently, even clinically, in another language, why couldn't I use them to interpret, especially considering the shortage of interpreters?
I'm going to say I could speak a lot about this, but I'm going to keep it concise. So when you have to have the training. Being bilingual is not sufficient. You need to have the training. You need to know how to interpret it. You need to know how to be a clarifier. You need to know how to be a cultural broker. You need to have all of those skill sets. And let's face it, your memorization skills may not be there. An interpreter has an incredible depth of being able to retain information. We have skills like counting, like the doctor says. So 3 things I want you to keep in mind. And you may see the interpreter like going 1, 2, 3 with their fingers, kind of like holding them down so that they don't forget something. The interpreter self-checks. Bilingual staff people do not do that. They don't know how to do that. They don't know how to do the first person. There's a whole ethical component. And you're right, I'm going to kind of mix things up a little bit. It's extremely challenging to find people that are qualified. My former HR folks would say to me, I don't understand why you can't find Cape Verdean Creole interpreters. We're in Brockton, Massachusetts. It's the Cape Verdean Mecca of the world. There are more Cape Verdeans in Massachusetts than there are on the Cape Verdean Islands. Well, that's great, but they speak Cape Verdean Creole, but they don't have the fluency in English at the depth that we need, right? And they don't have the training. The training I can provide, but I can't teach them how to speak English. They usually say that a person acculturates for language. It takes 7 years to be somewhat fluent. 7 years of being immersed into the culture. So the most challenging thing for me was finding the people, right? So you don't want to go to the path of least resistance and say, well, you've got 10 bilingual nurses. Why can't they interpret? Many, many reasons. First of all, legally, you are required to be able to prove that you have vetted these people, right? First of all, let's just talk about being bilingual. Me as a nurse, practicing under the scope of my license and practice. I've got a group of 3 out of my 6 patients are Spanish speaking. Why can't I speak to them directly? Why do I have to call the interpreter? Why do I have to wait? Well, you don't have to as long as you legally have been vetted, which means an assessment, a test, right? It's required by both Section 1557 and also the Joint Commission. You have to be deemed qualified, just like anything else. If you're going to do a certain procedure, there's usually an annual competency. You've got to be deemed qualified. So the only way really to do this is to test that bilingual staff person, right? This was probably the most challenging thing I've ever done in my career. I literally was black and blue from bruises because it was such a painful process, but it was the most rewarding process because it resulted in great, safe, effective patient communication. The assessment that I had was not difficult, but when someone did not pass it, it became very challenging, argumentative. It was almost like I was eviscerating them, leaving them to bleed at the side of the hallway. I would constantly hear, but I took 4 years of Spanish in high school or in college. Often those that were truly bilingual and bicultural, first language, I speak to my parents and grandparents in Spanish all the time. I even go to Spanish mass. What do you mean? This has got to be a mistake that I didn't pass. Well, it doesn't mean that you're not fluent. It means that you don't have the clinical fluency, which is very different than just conversing at the kitchen table. Hey, Ma, pass me the chicken and I'm going to kill my sister. You're not talking about salpingo-oophorectomies and, whatever else you're talking about, right? So it is vital that they have to be able to have the terminology in order to be able to deliver the diagnoses and the treatment plan. You can learn that. I can't learn to teach you the language. So on average, 40% of the people that took this assessment failed the first time. And as time went on, Debbie, they would say to me, some of these folks, Carla, I know I gave you a hard time, and I know now that I wasn't ready, and this credential, by the way, let's say you get sued by a patient and they state that your Spanish was awful. Well, this credential is done by a neutral party. It will actually help mitigate situations in court or legal situations. Trust me, I've been there several times with people, and it will show that, listen, I was deemed that I was able and that I'm able to converse medically in this language. The other interesting thing that I found just by accident is one of our physician practices called me and said, hey, our medical malpractice insurance person is here. And they're telling us that they're going to reduce our carrier fees because we have interpreters available and because our bilingual staff have taken this assessment. It reduces the risk. And, you know, that is really important. And I wanted to just share one little caveat about medical malpractice insurance while I'm here. So when I used to do risk management CME lectures for physicians, this is the one thing that would absolutely, you know, wake them up completely. And the reality is, if you don't provide a qualified medical interpreter to your patient, you are therefore violating their personal civil rights. And violations of civil rights are not covered by medical malpractice insurance. There's a rheumatologist a few years back in New Jersey that was seeing a patient who was deaf in his private practice. And she asked for an interpreter. He refused because he said it was too expensive. It would have cost him at the time $500 for her 3 visits. And he, you know, she didn't know her diagnosis. She didn't know her prognosis. She didn't understand the meds that she was taking. She filed a legal action, and he ended up out of pocket having to pay $460,000 because of the legal fees and pain and suffering. He did everything medically right, Debbie. This man did not make a mistake, but it didn't matter because he violated his civil rights. So people need to know this. And you also need to be aware that you can write this off as a tax write-off when you provide this. So I'm not quite sure I answered your whole question, but hopefully I did.
Yeah. One of the things that that I have spoken with other nurses about is also the ability, you know, as an interpreter, we are obligated ethically to remain neutral. And it's really difficult to do that when you're a nurse who's trying to do both roles. It's impossible, actually.
I will tell you firsthand, I know it's impossible. And 42 hospitals, and every hospital has its own culture. I mean, for goodness sakes, every shift has its own culture. Let's be frank. There was one hospital in particular that insisted that they wanted their bilingual staff to become interpreters, do a dual role. And, you know, it was an epic fail. I said, okay, we're going to pilot it on one unit. It was an epic fail. And the reason it failed, it's created a conflict of interest, and it compromises the quality of care. As a nurse being called in, you've got maybe 6 patients or whatever on whatever shift, and you have a consult. A doctor comes in, a neurologist consult, and they ask for your help. You could be in there 30 to 45 minutes. Who's taking care of your patients? Your other colleagues that are already stressed out and, you know, running around? It doesn't work out well. And as a nurse, what I found, and I think that I can try to remain neutral, but what I found, I couldn't turn it on and off. There were certain ways that I would say things or certain tones that I would use when I was trying to influence a patient in being compliant with what was best for them clinically. And that really took away from their communication autonomy and their ability to make a decision. Because if I had just conveyed the information in a neutral and confidential fashion as an interpreter, then that patient can ultimately make the decision. But if I'm setting things up so that, you know, I make it sound a little bit better, or, you know, I twist the words around, that is not a good way of utilizing my skills as a nurse. And as I'm interpreting, even if it's my patient and I'm interpreting for someone that doesn't speak the language and the patient doesn't speak English, I can't focus on my clinical obligations because my brain is completely immersed in doing what I'm supposed to be doing, which is interpreting.
Absolutely. Yeah. We have about 15 minutes left before the top of the hour, and we have I have a couple more questions, but we have 3 questions in our Q&A that I want to address or have you address. So the first one is in emergency situations where time is of the essence, do you recommend waiting for an interpreter versus proceeding without interpretation?
All right, so you're talking to a former ER nurse, right? I mean, how many times did we get patients that could not speak at all, right?
Sure.
Just trying to assess them and stabilize them. So I would always get an interpreter. However, that being said, let's just be frank, you know, you're going to stabilize that patient. As you're stabilizing that patient, you're yelling for somebody to get an interpreter or get the VRI iPad or get whatever it is.
Mhm.
You're not going to let that prevent you from doing what you need to do. But at the same time, it should be as natural as walking in a room and washing your hands, right? Or walking out and washing your hands. An interpreter should be part of the team. One of the best practices I put in place in an emergency room is that on the patient board where they had their name, it also identified the need for an interpreter. So it was a quick
Nice.
glance. So even before I went into the room to assess a patient, now mind you, not one that was bleeding out or crashing, you would say, interpreter needed, and I would know to grab the iPad or whatever else. But, you could argue if I didn't intervene, that patient would die. But I could argue that because you intervened and didn't ask me about my allergies, I died. Well, I wouldn't be able to
Sure.
argue because I'd be dead. But you understand what I'm saying. So
Exactly.
it's a sensitive question, and as much as I am a person that likes to follow the rules, I'm always going to do what I feel is best for the patient.
Mhm.
For instance, you're not allowed to use children as interpreters unless it's life-threatening. Unless that question that you could ask that child would save that person, and
Sure.
only until an interpreter is secured, right? So they've made those caveats because they want to make sure that somebody doesn't say, hands off, we got to wait for the interpreter, and that you do what you're there to do, which is to stabilize the patient and to hopefully save them.
Yeah. Excellent. Excellent. I'm saving my favorite question for last. It's about AI. But let me ask this other question first. Interpretation, I'm just going to read the whole question to you. Interpretation is very critical, not only to patient adherence and the patient experience, it's critical to patient safety, quality, and ensuring high reliability and just culture through following a standard process of interpretation. Can you share some of the best practices of how other healthcare systems are looking at tracking their LEP patient data, limited English proficient patient data, to ensure that they're mitigating disparate outcomes based on language of the patient?
That's a whole other 3-hour webinar. However, I will tell you that some of the best practices that I had put into place and that I learned from other people, because I am not that smart. I learned from others like Debbie as well. But it's like, the length of stay. We found that, LEPs, so people who are deaf, had a little bit of a higher length of stay. And we couldn't figure out why. That in the ER, for instance, this was a whopper. We had a much, much higher left without being seen rate
Right.
from LEPs.
Yeah.
Why? Because they're sitting there, and they see other people being taken, and they don't realize that it's a triage process. And no one comes up to them and says, we know you've been waiting, blah, blah, blah. So they just get frustrated and leave. We've seen a higher rate of AMA, leaving without against medical advice. And the recidivism back within 30 days, which we all want to try to avoid, is also higher for LEPs and patients who are deaf generally, right? So it's putting those things into place, monitoring the data, and also looking at your morbidity factors, right? Do you have patients who are LEP or maybe Hispanic or Black or Asian that dying at a higher rate from CHF than you do those that are white, when all other factors are the same insurance, same this, same that? So it's beyond my pay grade to look at all that data, because it frankly makes my head spin. But you have to look at that. One hospital did a study I loved, UMass Medical Center in Massachusetts, in Worcester, where they did a 3 to 5 year study where they showed that a patient who had an interpreter at admission and at discharge, and nowhere in between, just at those two places, had a much lower length of stay and a 33% less chance of returning than one that didn't have anybody.
Not that we're advocating for just the beginning and the end.
Never, of course.
Right. But yes.
Not at all. And then the other thing is Massachusetts just did something really first in the country, where they tied in Joint Commission Health Equity certification. All of the hospitals have that. But now there's an incentive financially, and that's what we all need. We need more financial reimbursements, right? To You can't have a mission without a margin. You have to make the money to be able to do this. But now they're talking about $400 million more in the pool by following this. So I am sure I'm doing a presentation on the Becker's a webinar on June 11th with Joint Commission and a lawyer specifically about this. I'm sure other states are going to follow suit. So,
and by this, you're referring to the new final ruling for Section 1557,
no,
right?
I'm referring to the fact that Massachusetts found a way to get all of their hospitals on the same page, and believe me, there's a lot of them, to say we're going to be accredited through the Joint Commission Health Equity Standards, and therefore we're going to meet. It's a 0 to 3 year plan, and we grabbed the race, ethnicity, and language of every single patient 90% of the time. You get a certain percentage more. So, you know, it's stratifying data and doing things to decrease disparities, but, you know, asking people to do more work without giving the reimbursement that's appropriate for it, it makes it almost impossible.
Absolutely. Absolutely. Okay, I want to move on because we only have 9 minutes left. So let's talk about AI. So we don't use, a lot of people have tried to use Google Translate, especially like if you've got a quick message back and forth with a patient. We've used Google Translate when we've created, you know, simple signage in the hospital. So why can't I use apps like Google Translate? That's part one of my question. And then let me read the other part of this question that came up in our Q&A. At what point will AI and other machine translation apps become good enough to replace human medical translators or interpreters?
Okay, so I belong on a task force that's a national task force that's called Safe AI. And we're setting up guidelines nationally and working with DC and a bunch of the regulators to make sure that AI is not evil, by the way. I think AI is going to be good. It's already saving, mammograms are showing 30% more cancers are evident through AI. So it's not the root of all evil and needs to be destroyed. It just needs to be utilized digitally, and you've got to have guardrails around it. So I think AI tools have made significant advancements, but you know, as you know, with Google Translate, it's just not there in the medical context. The nuances of medicine, the nuances of the language in context, the cultural references, it just can't do that yet. But it's come a long way. It's come a heck of a long way. Here's the other thing it doesn't allow for: confidentiality and privacy. You're transmitting patient health information through third parties. Who's responsible for that? That's a HIPAA thing. Okay. Are there potential breaches or unauthorized access? Who owns the data? Who owns the information? And by the way, if you have AI in your hospital, you should have your patients realize that whatever they're having done is through the assistance of AI. People have the right to know that, right? So there's a part of what President Biden just released with Section 1557 speaks to that at length. There's 568 pages. My eyes are glazing over. I'm only halfway there. So there's regulatory compliance that also speaks to the fact that you have to use qualified interpreters and translation services to ensure effective communication. Now, President Biden is not saying that you can't use machine-aided translations, written translation. What is clearly stated is that you have to have a qualified human interpreter vetted, so that if you're going to do an informed consent for surgery or some sort of procedure, and you're using whatever machine translation, good for you. But now it has to be vetted by a translator that is certified or qualified to ensure that it's actually accurate. So that's one thing, you know, and there's a lot of legal liabilities. And I just want to mention the thing that's most amazing to me is how AI is so biased. It learns from the past. But if it's learning from the past and we don't have enough research candidates for research studies that are Latino or that are Asian or that are Black or that are LEP, then it's going to make certain assumptions about things. For instance, the big one that really bothered me terribly was that the clinical algorithm about O2 SAT machines. So O2 SAT machines, a study of over 6,000 patients, determined that if you are Black or brown, it doesn't read your O2 SAT correctly. It actually adds about 5 points. So during COVID, if you were at 85% saturation, you probably would have had an intervention. However, yours was showing 90 just on the simple fact that your skin color was different, and it was adding 5 points to it. So again, negative outcomes for numerous people and numerous patients because these types of things had not been taken into account. There are languages that AI will never work with because they're so rare. I don't know how it's exactly going to work with ASL. We've got a whole team of people working on that. So I would say to you that I think that it's going to really be able to augment things like kiosks, directions, reminder calls, registration, maybe even the patient portals, right? It may be able to help with that. But whenever you introduce humanity and it meets science, there's a lot of emotions and variables that machine or that AI software is not going to be able to get. And that's my humble opinion anyway.
Yeah. One of the things that I say to people, I'm also a sign language interpreter, and people have asked me, well, for deaf individuals, isn't captioning or writing back and forth, isn't that good enough? And my response is, number one, not everybody reads at the same level. And number two, could you imagine sitting through this, for example, our dialogue back and forth? Could you imagine only having access to it through text and not being able to hear voice tone and intonation? And did you say something that was sarcastic or did you really mean that? Those are things that AI doesn't always catch. So, so vetting things through human translation is so critical.
And many of my deaf patients have said to me, I went to school to learn how to sign. I did not go to school to learn how to read English. So their English level is somewhat limited, right? So there's too many nuances. And I think we need to remember that we're dealing with human beings. And if these machine-aided things can help us, if they can take the burden off a doctor by avoiding 5 steps that they need to do with looking at a chart or whatever, I'm all for it. But let's not lose that connection that we have, that we need to have, that makes us different from machines. I mean, it's just, I think it's going to work wonderfully in certain aspects, and I think it's going to have to really be monitored in other aspects and tested.
Yeah, absolutely. Well, thank you so much. This has been wonderful. I want to point out to everybody who's still on our call that in the chat function, you will see a very important link to our feedback survey, which we would like to invite you to complete before logging off. So please do that. Take a moment to click on that link now to provide your feedback. The Office of DEIB values your feedback and uses your responses to help improve and shape future programming. So thank you once again for joining us today. And we look forward to seeing you at the next session of Inclusive Insights. And Carla, I have just so thoroughly enjoyed spending this hour with you. It's been really, really wonderful.
Thank you. And if you need anything, you let me know. And I'm so impressed with your organization. Keep up the good work. And, fight the good fight, because there's a lot of work for us to do. So
there sure is. Yeah.
Thank you so much for having me.
Thank you very much.